There he is. Good morning, everyone. I will call to order our meeting. Madam Clerk, if you wouldn't mind calling the roll.
Chair Braybeck.
Here.
Representatives Arbit,
Present.
Mahutsky,
Present.
Glanville,
Present.
Edwards,
Here.
McDonald,
Present.
Reingans,
Present.
Schmaltz,
Present.
Hoadley,
Here.
St. Germain,
Here.
Thompson.
Present.
Madam Chair, you have 11 members present. You do have a quorum.
Thank you, I appreciate it. Minority Vice Chair Smoltz moves to approve our minutes without objection. Thank you so much. And now I'm excited. I know we all got to, when we were talking about how we were going to think about this work, I said the two biggest issues that we have that are facing us are access and workforce. And today we are I feel very lucky to have some experts in this field of workforce who are going to be here with us to talk about different aspects. Thank you, Molly. To talk about different aspects of mental health care workforce and not only some of the issues, but some of the solutions for our consideration. And so I'm very excited and grateful for all of their expertise. And first we have Dr. Cheryl Kubiak. She's with us via Zoom. Dr. Kubiak is the Dean and Professor and Director of the Center for Behavioral Health and Justice at Wayne State University. Good morning, Dr. Kubiak.
Good morning, everyone.
Thank you for being here.
For not being there in person. I would love to be there, but it just didn't work out timing-wise today.
No problem. We are happy that you're able to join us and grateful that you're there because then we get more of your time. So thank you. Please begin when you're ready.
All right. I think that it's no surprise to anyone that we are in a workforce shortage. This is due to a number of factors, but I think that the COVID-19 exacerbated mental health symptoms as it also decreased our workforce. So we know that evidence statewide exists that the Forensic Center has doubled the amount of competency exams requested in 2022. And this results in things like people waiting in jails for this forensic evaluation before anything can be done, and sometimes staying in jail longer than any sentence they would have endured because of their crime, waiting for this examination. I will tell you how critical this has become when a Washington Post reporter contacted me last week wanting to run a story about the length of time people are spending in jails in Michigan waiting for competency hearings. We also see that our psychiatric beds in the state were low to begin with pre-COVID, but now we have waits of up to 6 months for a psychiatric bed. Again, this is a real issue, especially when you talk about criminal legal. I think that the other thing that we're finding is emergency rooms are inundated with people with behavioral health disorders, and this is not the space. We are working very diligently on trying to connect our hospitals with a continuity of care in the community, but at this point in time, that connection is not strong, and many times people are left floundering in the community after an ER visit. We also have things like Hawthorne closed half its beds, not because there wasn't the need, but because they didn't have the staff. This is, a child psychiatry unit. And I think that the other thing that I know I've been a party to this week is the juvenile detention situation. Because we do not have workers in residential treatment programs, youth have not been able to transition from detention to these behavioral health homes. And so they're languishing. We've gone in Wayne County from an average of 21 days in detention to over 100 days. And if you think about the mental health of a youth, that's a significant time away from the community, not to mention the overcrowding conditions and the dangerousness that has manifested inside. A 2021 survey of Wayne County found that vacancies in clinical positions in our public sector mental health organizations And when I say behavioral health, I'm including mental health and substance use disorders. That was averaged 30% across the 23 organizations in Southeast Michigan, 30% vacancy rate for clinical positions. So while we're increasing dollars for programs, like for instance, we had a earmark in the budget last year to open up a psychiatric hospital. My question is, staffed by whom? We can build the bricks and mortar, we can fund programs, but if we don't pay attention to the workforce, these programs are not going to be filled and will have the community problems. I think that the critical need, as I said, post-pandemic, we know there's an increase in everything from trauma-related symptoms to sleep disorders to suicide post the pandemic, mostly stemming from the isolation and the fear that people experienced and still experience. I know I can walk around downtown and still see people wearing masks out in the fresh air. So we still have that level of fear and trauma post-pandemic that both are manifesting in youth as well as adults. The consequences of unmet need we also see manifested in other ways: increased homelessness, increased crime, increased family disruptions, so that we know that by funding workforce initiatives, we may be able to decrease other social problems. I also fear, because I'm not only the Dean of the School of Social Work, but Director of the Center for Behavioral Health and Justice. We are intently working in 34 counties around the state, trying to divert and deflect individuals from jails and incarceration, sentencing, whenever possible, to get into treatment. We've made tremendous gains in this state with the Mental Health Diversion Council, the funding that's been afforded to that diversion council. I fear that the gains we've made over the last 5 to 10 years will be eradicated if we now have no programs to defer people to. That won't last long if a law enforcement officer has nowhere to take someone. Jail is the likely spot. Last but not least are the consequences with the opioid use disorder. We know that the workforce around substance use, prevention and intervention, from direct care workers to clinicians to case managers, is down considerably. And with these efforts towards eradicating the effects of the opioid use disorder, that workforce shortage is also affecting our efficacy in those efforts. So I want to say this, not to prejudice the dialogue in any way in terms of what workforce, because across the board we need psychiatrists, clinical nurses, psychologists, social workers, direct care staff. But I will say that social workers are the #1 provider of behavioral health services, not only in this state, but nationally. There are 29,000 social workers licensed in the state of Michigan, but that number is declining, and declining at a rapid rate for a number of reasons that I'd like to illuminate and then talk about recommendations. So first, I think that enrollment is declining at many master's programs. This is not social work specific, but across the board in higher ed post-pandemic, we've seen a decline in enrollment for graduate programs. The jobs are plentiful, wages are going up in some of these sectors, so students or community members don't necessarily see the need to seek additional employment, or I'm sorry, education to master's degree. The other thing is the return on investment for social workers. On average, at Wayne State University, go in debt $60,000 and are likely to make $45,000 in the community at entry-level jobs. That means a wage where they can barely support their families, let alone pay back student loans. So that they're considering, I think this generation of students are far more savvy than I was, and the cost of education has accelerated. While there's a lot of support for undergrad programs, there's little support for master's programs. And so I think that that equation that they're doing in their head about return on investment for their education dollars versus earnings has them thinking elsewhere. The second thing is licensure obstacles. Michigan has some of the most stringent social work licensing laws in the country. I know this because I head a national task force on social work licensing. There are regulations in our social work regulations for licensure that say that we don't pass an entry-level exam and then practice in this state. We have to pass the advanced clinical exam to be able to retain our social work license. So that's the highest standard of licensure. Entry-level social workers coming out have to do supervised hours, but they also have to take this advanced exam. If they don't pass that exam within 6 years, they can no longer call themselves a social worker, and they can no longer hold social work jobs that require licensure. So we are losing social workers at a time when we need them most. And I can tell you 4 cases that I know personally that people are losing their jobs this week because they cannot pass that exam. We know that the exam has the recent data that was released in 2022 says that this exam, which is used nationally, has disparate outcomes. That we know that Black graduates of social work programs are far less likely to pass that exam than our white students. This is not an educational issue, this is an exam issue. And while we work nationally to try to change that, we have to do something here locally to change those licensure laws now, or those regulations now, or create some kind of a public health emergency statute that allows these social workers to come back to the field. They have been supervised for 6 years in the field. If they don't have an infraction, they should be allowed to practice. Our communities need them desperately right now. So I would like to suggest some recommendations as a way to incentivize people into the field. I think we have to restructure the loan payment. The governor's budget allowed $5 million in loan repayment across the board, psychologists, social workers, psychiatrists, nursing. That is very little money. And the federal guidelines say you have to work in a field for 10 years in an underserved area before you can collect any benefit. If I'm working for 10 years at social work wages, it's not very helpful to have loan repayment. I mean, in the end, absolutely yes, but how do we, it's not an incentive for the 10 years that you're practicing making very low wages. I think that we also have to think about how we can incentivize. And one of the ways that we can do that is by funding internships. Social workers in particular have to do 960 hours of internship during their master's education. This is not paid internships, and in fact, our students pay credits for their supervision. So they're paying tuition, not making a salary. So we've been trying to work on things like using opioid settlement dollars. Can we use those dollars from the state to fund stipends to encourage students to go into substance use treatment professions? We've had some federal HRSA grants that do the same thing. They provide stipends. That's such an incentive for students to come into those areas. We do it with child welfare through Title IV-E funding to give students stipends so that, and then they make a promise to work in child welfare. Every semester they get a stipend for, they have to work 6 months in the child welfare. So we have models to incentivize students to come in, and we can support them. And finally, I'm working on this with many legislators currently, as well as the National Association of Social Workers and Lara, but I think that we have to do something around the regulations of licensure. And we need to do that quickly. When Illinois and Rhode Island changed their regulations, Illinois in particular was able to allow 6,000 social workers back into the profession after modifying their regulations. So I think these are things that we can do and that we should do, and that I look forward to working with all of you to do that. So I will stop my blabbering and open it up to any questions or comments or insights, because I really am looking forward to hearing.
Thank you, Dr. Kubiak. I know when I hear some of the numbers, I'm always astounded at what we're facing, and so appreciate your expertise. Rep. Thompson, let's start with you.
Thank you, Madam Chair. Thank you very much. You actually gave us solutions. I love seeing that. A lot of time we just hear, here's the problem, this is so big, but nobody actually comes up with solutions. So I have a few questions regarding that, just two. As far as the exam issue, you said that it's not an education concern why social workers are not passing this exam, advanced clinical exam, and you said that it's more minorities that aren't able to pass this exam.
Yeah.
What do you feel is the hurdle if it's not being educated or having the concepts or the rationales to be able to pass the exam? What do you think some of the hurdles are that they're not passing this exam?
So before I answer your question, I just want to say that there's a very rigorous accreditation that all schools of social work have to go through every 7 years. In that process, we have to assess student competencies all along the way, both for coursework and for their internship education. When they cannot take that exam for 2 to 3 years after they graduate. The exam is a multiple choice exam where all the answers are right. You just are supposed to pick the best one. So we did an experiment. We used the IA, that chat GPT, and we just published a paper on taking these exam questions and why, this artificial intelligence got 67% of the questions right. But when we asked for a rationale, when the answer was wrong on the chat GPT versus what the vendor says is the right answer, it gave a rationale that was incredibly insightful and incredibly correct. But sometimes what we teach or how we teach social workers to operate in the community is take a 360 of everything that's going on and what is the needs of that individual at that time. So my perception of a need might be different based on the experience or what I prioritize as a need. And I'll give you one quick example. In the test, it said something about you run, it was a scenario, and it said you run across a child, parents are alcoholics, and what's your first thing to do? And it gave, remove the child, blah, blah, blah. It did not say an option for assessing the situation and the strengths and needs of the individual. The IA, the chat GPT, said that as a rationale. The first thing you need to do is do an assessment, which is correct. And it wasn't an exam option. And so I think that those are things that when we teach social workers to look at context, look at community, look at strengths, it's not easy to answer in a way that you pick a multiple choice response. And that multiple choice response may differ from what our experiences are. If I'm going into a home because of substance abuse and it's someone who has resources or children aren't endangered or whatever my experience is, that might be totally different from someone who comes from a different community where there are no resources, where the community isn't safe, that you can't say, yeah, let's go and do some pro-social activities and walk around, or you have to consider the context. And every student has a different context that they experience or they know. the test does not seem to honor those unique experiences.
With that,
Because,
I'm so sorry.
sorry.
I was just going to say, with that being said, because I actually am a nurse and I was able to pass the NCLEX, so I understand the process of multiple choice answers and getting and obtaining your critical thinking, because every answer sounds right. Two of them are absolutely correct. One of them is the best answer. So it makes me a little nervous, to be honest, with everyone, if you talk about kind of dumbing down tests, and I don't want to say it like that because I don't mean dumbing down, but it sounds like if we're not getting our social workers able to pass this test,
Yeah.
but they're educated, I can understand the concept of having different scenarios or not doing assessment. But in my mind, just because the answer was an assessment, does that necessarily mean that they wouldn't already know to assess? So looking at this national exam, and I am not a social worker, so I understand the totally difference in the practice of your profession. Looking at regulations, I think across the board in healthcare is huge for our state, looking at what other states are doing, looking at what our scope is and the regulations within Michigan, because I do agree, they are pretty stringent for healthcare professionals, social workers in general across the board. And then in regards, just one last quick question, in regards to the loan repayment, are any of these, is anyone encouraging people, if their loans are through Nelnet or whoever carries their loans, if they're looking for income-based payments, where because I still have student loans, but I use an income-based option. So for many years, I was able to have a $0 payment while making $65,000 as a nurse with 3 children. I still had a 0 payment for many years. So, and
Yeah,
that would be the only question. Thank you.
Yeah, I want to first come back to the exam, and I'm not suggesting that we don't have an exam or we dumb down the exam. I'm saying that I have a nursing license as well, and I understand the differences between the 2 exams. And that one of the things I would say is that maybe it's a different type of testing, that you examine critical thinking in more of a scenario or a written explanation of what your steps would be, not a multiple choice that pulls it. Nursing, it's a little bit more fact-based around, here's the drug you'd give, or the, test you'd suggest, or this is, I think, a little bit grayer sometimes. And I think that we need just a different testing mechanism. So I just wanted to be clear about that. In terms of the loan repayment options, I do think that has been the experience of some, but I will, in terms of the zero-based, but I will tell you that nationally, 98% of social workers are not successful in their bids for loan repayment, either because they move from that high need area, trying to create an income increase, but it just hasn't been, that 10-year span of time has not been a successful option as social workers try to increase their revenue through income.
Let's go, Rep. Edwards.
Thank you, Madam Chair. Thank you for bringing highlight to this situation in regards to the lack of social workers and also regarding the regulation process. As one of the Black individuals who have not been able to pass this exam multiple times, who also have several friends and several individuals in the Black community who have not been able to pass this exam, and we're not asking for it to be dummied down. We're really just asking for an understanding as to why there's a higher number of Black individuals who cannot pass this exam. We do want to provide the services that we're trained to do, but we are hit with the issue with the regulation and the licensure process, which is really unfortunate, especially for someone who has a heart for doing social work. I also would like to add, I worked in the area of child welfare, so I understand the need of having that extra layer of incentives for those who are going to work in the area, because that, again, is a stressful area. We all know that dealing with children being removed from their home causes traumatic experiences for the worker and for the child and the family as a whole. So again, I appreciate you for bringing highlight and showing that there is an issue with this, because I have been advocating for changes in the regulation, even if we just mimic the changes that Illinois has created, will be one of the solutions. So again, I appreciate you for bringing highlight and bringing attention to those barriers.
I look forward to working with you, Rep. Edwards. I agree with you a lot. We're losing some incredible supports and resources in communities that need them most. It's not about dumbing it down. It's really about getting the right assessment. And we are working on that nationally. But I think that this type of format in this exam doesn't allow anyone to assess the thought process and the critical thinking that needs to go into every social worker's judgment. So that's, yeah, the only thing that I don't think that's dumbing it down at all. I think that's improving our assessment and testing mechanisms.
Thank you.
Thank you, Rep. Edwards. Rep. Glanville is going to be next, but Rep., if you mind, I just want to make a comment about the testing. My experience, I took the psychology test, and it's very similar. You have multiple answers that are all correct, and for me, the way my brain works is, oh well, in this situation this can work, in this situation this can work, and I go through, and so I always struggle and have always struggled with standardized tests. So I can remember studying for that exam. It's called the EPPP. I'm studying for it, and my husband comes in, who is a very good test taker. He looks at the question. He's like, "Oh, it's that one," and I was like, "Get out." And so it was more a marker of being able to ask. He knew nothing. I mean, like I literally had 2 years of an MSW program, 4 years of a doc program. It wasn't because I didn't know the material, and he certainly didn't know the material. And so it really is about test taking, particularly because of what Dean Kubiak was saying, kind of the way that our profession works and all the things we have to consider when we're engaging. And so I'm glad we're having this conversation, and I'm grateful for all the comments. So thank you. Rep. Edwards. I'm sorry, Rep. Glanville.
Thank you, Madam Chair, and thank you for being here today. So I'm going to put my educator hat on because I'm not a social worker. And just to echo some of the comments here, I think it is very widely known why high-stakes testing doesn't work. It has been shown over and over again that there are numerous biases within that kind of testing system, and we have seen that being overhauled at all age levels. I mean, K through you name it. So I'm a little bit disappointed that this hasn't reached this level of the social work industry at this point. But I did want to kind of just clarify a couple of things. Did you say that this is the highest level test? So would that mean there are other exams that you might be able to take at a lower level? Is that?
Yeah, there's multiple levels of testing in Michigan. There's a tech, which is like an associate degree, and there's a bachelor's level. There's a kind of a limited license of a new MSW, and then there's the advanced clinical. And when Michigan put licensure in, they went straight to the advanced clinical, and their thinking was, let's save people money. These exams are $250 a shot. Let's save people money, and let's just go for this higher level one.
Right. Don't get me started on the money-making machine of the high-stakes testing industry. But so I hear you saying there's an opportunity to use other tests. But what I want to also circle back to is something you mentioned about the guidance process throughout that you're doing observations and working maybe in a competency or skill-based method throughout the program of study in social work. Is that correct?
Yes, I mean, we actually now have students taking the exam in their final 2 semesters, but our accreditation is set up to demonstrate. We have to demonstrate competencies, that the students attain these 8 competencies before graduation, and we have to collect data on every course we teach, on every field education experience, and turn those into our accrediting body.
Okay, fantastic. I'm also the chair of higher ed and working diligently in this competency-based space and hoping that we can make some forward movement there because frankly, it's duplicative to go through a competency-based model and then have to take a high-stakes test at the end, where typically the high-stakes test does nothing to demonstrate your actual competency at the work that you're doing. So thank you.
Thank you, Rep. Glanville.
Yes, thank you.
Well, Dr. Kubiak, thank you so much. We really appreciate both your expertise and, as Rep. Thompson said, and I agree, coming with recommendations as well. That has been one of the things that's so vital when we are talking about the workforce issues and giving us some ideas about the continued things that we can work on. So thank you, and thank you for spending this time with us this morning.
It's been a pleasure, and if there's anything I can do to help or support your efforts, please call. This is very important to not only our school, but the communities that we work in.
Yeah.
So thank you very much.
Absolutely. Thank you.
Bye-bye.
Take care. So we're going to move on, colleagues. We have another speaker who's with us here today. Dr. Claire Luz is here, and she's an associate professor at MSU and in the College of Osteopathic Medicine. And she's also the founding director of MSU Age Alive and the Impart Alliance. And that's how I got to meet her, was through her work in the Impart Alliance. And I think that what they are able to do in terms of this issue of workforce is really important and something that we all can learn from as we're thinking about solutions here. So good morning.
Can everyone hear me? Okay. First of all, thank you, Rep. Braybeck and all of the committee members for having me here today. I'm thrilled to have this opportunity. And thank you to Dr. Kubiak, as a former social worker for 20 years, all in long-term and support settings. I appreciate your comments. And I supervise a social work intern right now, so I understand some of these issues. Dr. Thompson, I hope I come with recommendations. Oh, sorry, Rep. Thompson. I hope I come with recommendations and some hopeful. I know you are often approached with, this is how dire the situation is. But it is dire. I'm here to talk about the direct care workforce. And let me just first tell you a little bit more about me. I am a gerontologist. I am the director of Impart Alliance, which is an organization whose sole mission is to help Michigan develop an infrastructure that can grow and stabilize and support the direct care workforce and the individuals that they serve and their families and our communities and our health systems and our economy. In addition, I am the co-chair of the Michigan Department of Health and Human Services Direct Care Workforce Advisory Committee and the chair of the statewide Direct Care Worker Coalition, which has about 750 members now. So in this capacity, I've had the really good fortune to work with people like Rep. Braybeck and Bob Stein, who's going to be speaking in just a moment. So I assume that you are aware that there is a critical shortage of direct care workers. And as we all struggle with the consequences of this severe shortage, I'm glad to have the chance to bring you some good news and some hope. And Rep. Braybeck has asked me to talk about all of the major coordinated initiatives that are happening right now at the state level to address this shortage, and there are many, and they are coordinated, and they are strategic, and they do give us an opportunity here in Michigan to address this problem. An unprecedented, rather stunning number of initiatives that have emerged, and I believe are important for you to know about so that we can work together. Over the past 3 years, advocates have been able to form very strong partnerships around this issue across all sectors. And we have reached consensus on multiple strategies and recommendations to tackle this problem on behalf of all direct care workers. As Bob is going to talk a little bit about the behavioral health direct care workers, there are approximately 50,000 direct care workers in the behavioral health space. But it is important for you to know that we estimate that there are another 150,000 direct care workers working in other spaces for a grand total of up to about 200,000 direct care workers here in Michigan. And they cut across all long-term supports and services settings, all programs, all populations served. And there are mental health concerns across all of these settings and all of these populations. There's so much overlap. The mental health issues in the aging world are huge, for example. So as said, I am going to share a little bit about these initiatives. I am aware, the ones I'm aware of and involved in, and I understand we will have time for questions, which I'm grateful for because I hope we can open up a dialogue about how to work together. First, though, I would like to provide a bit of context. I'm sorry, I do not know how much you know about direct care workers, and I think it's important for us to start on the same page. Have a common understanding of the framework that is guiding many of these initiatives, starting with a working definition of what I mean by the term direct care workers, as well as some basic facts about direct care workers. And I had a handout, which I did not bring, but I will forward it to all of you, that just provides some basic statistics about direct care workers. So this is a definition that I want to share with you. The various groups now working together learned early on that for health system changes and policy reforms, it is critical that we come to consensus as much as we can on who a direct care worker is, and what our common goals are, and use consistent terms, consistent messages when we approach the public, when we approach policymakers, so that everybody's on the same page and knows what we're talking about when we say direct care worker. So if we don't have that, it really undermines our common goals and our ability to move ahead. And there are multiple examples of this happening over the last few years. So this definition was developed by a group of leaders from across the state representing different constituencies who understand the need for this shared language. And this is a definition that we could all live with. So there might be things in here that you take issue with, but this is one that we could all live with. And it is meant to be as inclusive as possible in terms of the titles, the long-term supports and services settings, populations, programs, and payers. So we are using direct care worker as an umbrella term that refers to individuals who provide essential services through behavioral health, community mental health, long-term care systems, the waiver program, PACE, to support individuals with intellectual developmental disabilities and older adults, too, in a range of care settings, including their own homes. This includes all of these different titles, but not limited to certified nursing assistants, home health aides, hospice aides, personal care assistants, home health providers, direct support professionals. All of these titles fall under that category of direct care workers. It does not include RNs, LPNs, MedTechs, or other licensed or certified professionals. Most direct care workers are paid for through Medicaid, which puts a limit on how much we can pay them, how much money is available for training. It's not in the market economy like other jobs are. But they can also be covered by private insurance, by Medicare, or directly by their clients. Most have a core set of responsibilities centered around assisting with hands-on personal care, activities of daily living, rehabilitation, and habilitation. So that's the definition we're working from. Why is there a shortage? We actually know very well the answer to this question. These are the primary reasons, and I will let you know that back in 2003, I and some colleagues were commissioned by the state to conduct a study on turnover among direct care workers, because 20 years ago we saw this coming. We knew this was a problem, and the state was really interested in figuring out what to do about it before it became acute, which it is now. They wanted to get a handle on it. We surveyed an incredible number of direct care workers in Michigan, 1,100, and asked 3 basic questions. Why did you enter this field? Why do you stay in this field? And if you're thinking about leaving, why? And 20 years later, here we are. Not much has changed in terms of the job conditions. The reasons are still the same. But this time, because of the momentum of the work being done, because of COVID, because of the severity of the shortage, we have a very rare moment in time here, a fleeting moment, I might add, to respond differently and to change the tide. If we respond differently than we did 20 years ago. And please note that these reasons all lead to the main problem, which is a lack of economic security. So if we want to stabilize this workforce, we really need to work on making sure that they are economically stable. And economic security, the lack of it, this problem has really deep roots in that bottom bullet there. Institutional, historical, racism, sexism, ageism, and discrimination against a number of people that ends up marginalizing them. So the core of all of our efforts, I believe, has to be on establishing economic security for this workforce. And there is no doubt that wages are a major factor, but they are not the only factor. So the reasons for the shortage and the solutions are all interrelated, and I will demonstrate how in just a moment. And they have to be addressed simultaneously. So how severe is this shortage? This is the statistic that grabs people's attention. It is estimated that in Michigan alone, we need about 36,000 more direct care workers than we currently have. We actually needed them yesterday, a long time ago. The average turnover rate, if you look at all of the 200,000, but primarily I'm looking at home care at the moment, the average turnover rate is as high as 82%. Bob is going to mention, I think in behavioral health, it's about close to 42%, which is still too high. In home health, the estimates are higher. The cost to employers for every single turnover, every new hire, is about $2,400. And recent estimates from the Center for Healthcare Studies is that it is as high as $5,000 to $6,000 per turnover if you count both the direct and the indirect costs. This understandably destroys continuity of care, quality of care. It keeps the system churned up. It is astronomically costly. And this is not just a problem for long-term supports and services. This is a problem that affects all of us individually, all of us collectively. It affects our health systems, our economy, our economic development, housing, non-health care businesses. It affects everybody. Businesses are now shuttering their doors, turning people away, people who need critical care to actually live, survive. So this is a problem. And investing in direct care workers is, if for no other reason, the return on investment is high because the investment in the direct care workers is so much cheaper than the cost of turnover and 30-day rehospitalizations and nursing home admissions and all of these costly events that take place if you don't have a trained direct care workforce. So a major challenge facing all employers is how do we grow and stabilize this workforce? And I think you will all agree that we don't want just warm bodies. Yes, we need more. We need at least 36,000 more, but we don't want just anybody. We need people who are available, who are qualified, who are kind, who know what they are doing. We know that they are in a pivotal position. 20 years as a social worker, I agree with Dr. Kubiak, social work is critical. But it is the direct care workers that are in there every single day, establishing intimate relationships with people who can see even nuances in changes in mental health and physical health. We know they are in a pivotal position. A trained direct care worker can prevent falls, hospitalization, nursing home admissions, and improve health outcomes and quality of life for the people they support. With an untrained direct care worker, situations can go south quickly, and they can lead to life-threatening or life-altering, costly events. So this means they need to be competent. to do the job. So what is our main vision, all of us working together here? Our main vision is really very simple. I think this is what we all want. We just want a sufficient and stable supply of qualified direct care workers. It's quite easy. And we have been asking ourselves 4 primary questions. How do we attract direct care workers? How do we keep direct care workers? How do we make sure they're competent? And what needs to change to achieve competency and recruitment and retention goals? So we have some answers for that. And we are working, I and many of us generally put the strategies into 3 major buckets. And at the core, obviously, again, is the need to change the economic status of direct care workers, and wages and benefits are critical. Bob's going to talk about that a little bit more. But a second really critical strategy is to professionalize this workforce. And by that, I mean establishing some competencies, some training standards that wrap around those competencies, some credentials, some career paths, some career success models. This professionalization should lead to higher wages and benefits. That's the way it's supposed to work. That's why a lot of us went for a higher education. And then the third bucket is cultural change to increase the value that we place on caregivers and the people that they provide support to through, marketing campaigns and really reframing how important this workforce is. COVID has given us a chance to do that because it has demonstrated how essential this workforce is. So again, all of these strategies are inextricably linked. They need to be addressed simultaneously because increasing wages alone is not going to work. You can pay them $25. I don't think we want to pay them $25, $30 an hour if they don't know what they're doing and they're bringing harm to people. But training alone is not good either. As Dr. Kubiak was mentioning, you can have the best trained direct care in the world. It's not going to matter if we're only paying them $12, $13, $14 an hour, or they don't have a car to get to work, or gas money to put in the car. So a patchwork Band-Aid approach is just not going to get the job done. So this is what's happening now. It's all starting to come together. This is where I hope I'm hopeful for all of you and bring some good news. It's starting to come together. And let me give you a few examples of how this is happening. So what is happening in Michigan really feels like nothing short of a movement, and other states are taking notice, I guarantee you. I have been on several projects over the last couple of years studying what's going on in other states and trying to bring some of that back here, like what is working or not working in other states? What is working that we could maybe apply here in Michigan? But other states are noticing Michigan, and we are starting to take the lead in this because of all of the good work that's happening here. We should feel proud of this. But we can't let it slip away. We have to use this moment and leverage the momentum and these partnerships that have been developed. While we have the opportunity, before the window shuts, this is just a sampling of what's happening in Michigan right now. There are many other things happening, and I'm happy to say that there's now a lot of cross-coordination and pollination across all of these efforts, which is exactly how it should be. In studying the other states, the states that have been most successful are those that have had coordinated leadership at the top. And all of these groups working together, external allies, MDHHS, government officials, legislators, all working together. So let me point out that an important initiative was the strengthening of a legislative care caucus, which Rep. Brabeck is a strong supporter of. How's that? How does that sound? Get the right word here. So, and I know several of you have really been instrumental in developing this committee and have championed some of the proposals that we have brought forth, so thank you very much. Several of the initiatives, starting with the State Plan on Aging. Everything I've just talked about is baked right into the State Plan on Aging, which I think we can all get behind. As I said, other states are taking notice of this, and A second game changer really is the statewide Michigan Department of Health and Human Services Direct Care Workforce Advisory Committee, which was established in 2020. Our first meeting was in March after everything had shut down, so it was virtual. But to have that kind of support from within MDHHS was huge. It was unprecedented. This group has had 3 work groups. We now have another one. And I'm just going to tell you about that first one for a minute here. Let me say, though, that this is the first time I have ever been in a group where there is representation from all long-term supports and services settings. From behavioral health, aging services, Medicaid, regulatory folks, advocates, direct care workers, and others. And the key here is we're talking to each other. We're all talking to each other. We're developing relationships. We're finding common ground. And we have arrived at a point where we're committed to the same stated objectives and pulling in the same direction. We've been meeting monthly for 3 years now. And I can honestly say that every meeting leaves me impressed and grateful. Everybody has been showing up to every meeting. It's incredible. And it's a privilege to work with this group. So one of the work groups is this competency education credentialing work group. This work group focuses on professionalizing the direct care workforce, which I talked about earlier. You may know that there are federal competency and training requirements for certified nursing assistants, for home health aides, some hospice, but there is nothing, zero, comparable for the rest of the direct care workers. So step one was to establish some competency standards. It's really hard to develop training programs when you don't even know what the quality standards are and what you're training people to do. We did develop a list of competency standards, professional and ethical guidelines that were informed by national standards. We submitted these to MDHHS for consideration, and I'm happy to say that the department has adopted them. So Michigan now has set of direct care worker competency guidelines. They're not mandatory at this point, but that's a big step forward because we can now wrap training guidelines and credentials and career pathways around these quality standards. And we're not talking about training guidelines that supersede or replace other existing credentials like the CNAs. We're not talking about that. We're trying to increase options, not decrease options here. We're developing strategies that can move direct care workers more quickly into the job market without sacrificing quality. How do we do this quickly? So we're coming up with things like stackable training levels, each with associated credentials and competencies, so that people can get some foundational skills, get out in the job market, start working, and then maybe get additional training if they choose to do that. We're looking for ways for people with existing skills and credentials to test out because we want this to be competency-based. We're looking for reciprocity so that job skills are portable and can cut across all of these programs. The current system of every setting, every program, every payer having their own training requirements it's fractured, it's extremely inefficient, it's confusing, and it reduces options for employers and direct care workers. So we have to come up with a better system. In 21, Impart Alliance received a MICA grant. These grants are funded through the Michigan Department of Labor and Economic Development, and they are meant to establish employer-led collaboratives with the idea that a group of employers who share a common problem, in this case it's the direct care workforce shortage, to get together to come up with common solutions. So that's what we're doing. We are establishing a statewide employer-led collaborative that have the same goals that I just talked about, that are in the State Plan on Aging, that the Direct Care Workforce Advisory Committee has. We have the same goals. We have to, Leo dictates this, thankfully, rightfully so, that we work with employers, with Michigan Works agencies, with educational institutions on these solutions. And this grant is allowing us to actually implement all of the recommendations that everybody has for us. The Direct Care Workforce Advisory Committee makes recommendations, but then who's going to implement them? You have to have somebody to actually implement them. And that's what this grant is allowing us to do. Then, this past year, a major game changer happened thanks to the Michigan legislature and the governor. And that is the fact that a group of us, including Bob Stein and others, submitted a proposal to MDHHS for $2.8 million to establish a statewide direct care worker training and credentialing infrastructure. And this idea was included in the 2023 state budget that was approved. And I can't tell you how happy we are and how important this is. And I know that several of you and the Legislative Care Caucus really championed this, and we will be eternally grateful. So thank you. The proposal was to build on the MICA grant, and you have a copy of a one-page summary of it. I think it's been passed out. Melissa's passed it out, maybe. But it was to build on the MICA grant, which has laid the foundation for something bigger. And this is what we were hoping for. This is something bigger we were hoping for. And the idea is to have a central administrative unit for efficiency purposes, have a training arm, a credentialing arm, to create a system through which training that maps to the state-supported competency guidelines that we now have, that is accessible, affordable, and available at the local level through existing structures like the community colleges, the AAAs, the Michigan Works agencies, the high schools. This is exactly what we are now doing. It's allowing us to set up the bones of such an infrastructure. And we're going to need additional funds. But one thing I'm really happy about is we have just entered into an agreement with a consulting firm that is specialized in helping organizations determine the best financial sustainability model that we can land on to make sure that this is financially feasible and sustainable, so that we're not dependent on state dollars for all of the costs. We're going to figure out how to eventually get this self-sustaining. To circle back to some of my earlier statements, this is not just about training. An important component is developing career success models. We know we can't just drop somebody in a job and say, good luck, see you later. A lot of these people really need some career counseling. They need supportive services wrapped around them. They need help if they are going to succeed and not have this constant churn in the system. One last thing, I know I've said a lot, and I so appreciate this opportunity, but one more thing I do want to say is we have this new work group. This work group grew out of a recent study done in Michigan by the Center for Healthcare Strategies and public sector consultants called Forging a Path Forward to Strengthen Michigan's Direct Care Workforce, which clearly points out that the return on investment in our direct care workforce in terms of wages and training is the return is far greater than the cost of investing a bit of money in them. So because of these reports, the Direct Care Workforce Advisory Committee formed a work group to review all of the recommendations that have been given to us in Michigan, but also across the country, to determine which ones make most sense for Michigan. So we have been meeting regularly. During our first meeting, we discussed the fact that there are now these multiple lists, both national and specific to Michigan, and we need to pay attention to all of them. And it led to a good discussion on just what can this state of Michigan do as a state. And fortunately, there's a lot of good literature on this. We are systematically analyzing and synthesizing these recommendations from across the nation, and our goal is to present to you and the department a very lean, Michigan-specific list of recommendations. And we are very close to completing this list, and we can't wait to share it with you. We think it's going to be a very important tool because we're not just saying, oh, here's a long-term goal, here's a short-term goal. We're going to try to say, and this is how we make it happen. So stay tuned for that. And I think it's important to point out that all of these recommendations are kind of fall into the same categories I've already outlined, the categories that are outlined in the State Plan on Aging. So here again, one of the most important categories is a statewide coordinated leadership. It just can't be overemphasized. It's a key requirement for success at the state level, this coordinated leadership across all sectors. So we are now witnessing successes because of these coordinated efforts. These are just a few of the successes, including the 235-hour increase. Thank you so much. Very welcome. We need more, but it's a start. The competency guidelines I mentioned. So these are propelling us forward in ways we could not even dream of 2 or 3 years ago. And I just am, again, anxious to open up the discussion and basically, I've mentioned all of these, but talk with you about how we can do this together. And I'm going to end there. I know that was a lot of information, but thank you for bearing with me.
Thank you so much, Professor. We really appreciate it. Do you know, I know you said that the report would be from the policy recommendations group would be forthcoming. Do you have a month, a year?
Oh, not a year. No, we're hoping to have it ready to, it's going to go first to the Direct Care Workforce Advisory Committee.
Okay.
And then we will hopefully be able to distribute it to you.
Great.
And we hope, and Bob Stein behind me might be shaking his head, I can't see him, but we're hoping to have that to you in about 2 months.
Oh, great.
Yeah.
Wonderful. Okay. We'll start with Rep. Glanville.
Thank you, Madam Chair, and thank you, Dr. Luce, so much. I can't tell you how over the moon thrilled I am to hear how you described your competency and curriculum program. That because I've actually been having almost word for word that same conversation with people about direct care workers. I didn't realize you were doing this. So thank you. Check. That's off my list. But anything, I would love to stay engaged with you. We need to repeat this model in so many places in the state, and it applies to what we just talked about with our social care workers. Absolutely. This is the route we absolutely have to be taking in workforce development, and I just would be thrilled to work with you and learn more about how you put it all together and got to this end point, because
thank you.
Professionalizing these careers is absolutely what we need to be doing. So thank you so much for taking this on, and your vision is just astounding.
Thank you. And I look forward to working together.
Thank you, Rep. Reinkens.
Thank you. Thank you for being here. I am familiar with the profession of community health workers, which is a different profession, and they are also working on professionalization. And I think the goal of professionalization of a profession is to ensure that they can be paid more and justify the demand to be paid more. And so have you gotten commitment that when direct care workers are going through a process of extra training and education and then credentialing, which we just heard in the social work field actually seems to be preventing more social workers from being credentialed and trained and in the field. So now we're proposing to do this with another profession. Have you gotten commitment that this will then result in higher payments to the employing, like higher contracts to the employing organizations that employ direct care workers, which are not always governmental entities that have to follow those kind of contracting guidelines? So I'm just curious, because we're building this, and I'm hoping that the funding will come. I know we have some control over that in some cases, especially for Medicaid funding, but there's other funding sources too. So I'm curious if you've gotten to that yet, or is it just that everybody's watching and knowing that the asks are coming?
No, it is actually a very clear goal for all of us. We are hoping that all of this will lead to higher wages and benefits. It's a little unique with the direct care workers because a lot of the funding is through Medicaid. So it is very hard to be competitive with the service industry and some of the other jobs that are out there right now that are a lot easier and people make a lot more money. But so there has to be some systems changes for, I think, higher wages to occur. And I've listed on this slide, what's next. There's a lot of work to be done, and a lot of it is at the systems level, including the Medicaid reimbursement rates. We have to look at those. But Yes, to your question, the MICA grant through Leo is one of the requirements. We need to demonstrate that if we develop this training program and employers commit to sending workers through this program and then hiring them, that it is going to position these workers for higher wage jobs. That is the goal, and the employers know this. We're also looking at some really solid career success models like the apprenticeship programs, and built into the apprenticeship programs are things like, this needs to lead to higher wages, and employers who participate in that know this. So we're hoping that, so much of this is sort of, I keep saying we're building the plane as we fly it. And so it's evolving, but that is absolutely on our radar.
I guess just to clarify, since so much of our healthcare system is driven by the payers and what they will pay for,
Right.
have you gotten confirmation or commitment from the ones that will be paying the employers for the services provided by their employees, that they will in fact pay more so that the employers can then pay the employees more?
Yeah, I hear what you're saying, and again, I'm going to say, it's complicated because our system is so fractured. We have so many different payers for different populations served, and they each have their own requirements and source of payment coming to them, right? Mm-hmm. So one of the things we really have to do is straighten that system out and find something that's a little more standardized. We're hoping to develop some credentials that all payers recognize, mm-hmm. and that pay raises are cut across all of these sectors and simplify the system, mm-hmm. make it more efficient. But I'm trying to answer your question, and I'm happy to say that the people that make those decisions are at the table. We have people from LARA there, we have people from Medicaid there, so it's critical that we develop those relationships and have those conversations.
Great, thank you.
Yeah.
Thanks, Rep. Rep. St. Germain is expert. If you wouldn't mind asking a quick question. We have one more expert that we want to hear from, and I know folks have committee at 10:30. Thanks so much.
No problem. I just have one question, actually. I had the opportunity to tour a assisted living facility just last week. And do you think, as far as workforce, I understand that they're still under a mandate, a COVID-19 vaccine mandate and a mask mandate. Do you think that once that is finally lifted, that might help attract workforce?
Since you were the last question, if with permission, I would like to turn it over to Bob, because Bob knows everything you want to know about assisted living facilities.
Okay.
And I think he can handle that question for you.
Okay, no problem.
If that would
Thank
be
you.
all right.
That'd be great. Thank you so much. We're so grateful for your leadership in this, for our state, and for being here for all of us to continue to learn and figure out. So thank you so much.
Thank you for the opportunity. I appreciate it. And I look forward to working with everybody. We all do.
So next, I'd like to welcome up Bob Stein. Bob is the General Counsel for the Michigan Assisted Living Association. And Bob has been at the table with these conversations about direct care workers for years. We're happy you're here, Bob. Thanks for joining us.
Thank you, Madam Chair, and members of the committee. I'm Bob Stein, General Counsel with Michigan Assisted Living Association, and our nonprofit organization represents providers of both behavioral health and long-term care services, primarily with residential services. And to answer the specific question on assisted living, for assisted living, which typically would be licensed adult foster care homes and licensed homes for the aged, although there are other more independent settings that refer themselves as assisted living, technically the mask mandate does not apply any longer. That MDHHS did revise its order, and I can provide you with more details, but it did revise its order several months ago to eliminate the requirement to wear a mask in most instances. And of course, we're concerned about the health and safety of everyone, but that was creating a lot of consternation, an absolute mask mandate in all instances. Now, with reference to the workforce issues, first I'd like to emphasize we fully support the work of Impart Alliance. We appreciate the efforts of the Michigan Department of Health and Human Services, and we do think it takes a multi-pronged approach to workforce challenges that didn't start last year or the year before, maybe have been exacerbated by the pandemic, but they've really been with us for decades. And we've included in our packet 3 handouts, which I will provide the highlights of, and I know we're under time constraints. One is a workforce survey report that our organization and Encompass Michigan conducted just this month, and we've done it 6 consecutive years, for direct care workers or direct support staff in the behavioral health or community mental health system. And we think the data is important. You'll see in reviewing the highlights that for direct support staff, the average starting wage rate is $15.20 per hour. The turnover rate is comparable to last year. It's slightly less at 42% compared to 45%, but that may not be statistically significant. But the more telling statistics, we think, are percentage of open or unfilled direct support staff positions, 18.8%, which is interesting because the comment that Claire made about 36,000 direct support staff needed is about 20% of the total of 200,000 direct care workers. So I think it's fair. In some instances with clinicians, it's an even higher open rate, but we're looking at least about 20%. And then our survey respondents indicated that over 1/3 of them have health and or safety concerns for the individuals they support. What I would like to also emphasize is that funding for wage increases do make a difference. And we appreciate the support of the legislature and the administration for the $2.35 per hour wage increase, which started in April of 2020 as $2 per hour, and then, of course, was increased over time. There weren't much blessings to the pandemic, but it did create an awareness of the workforce crisis in behavioral health and long-term care, and it did create the impetus for that wage increase. We also appreciate the governor's recommendation for a $1.50 per hour wage increase in the next fiscal year. We candidly don't think it's enough. We've communicated, when I say we, MALA is part of a statewide coalition of a number of organizations, including the Community Mental Health Association of Michigan, Area Agencies on Aging Association of Michigan, the ARC Michigan, Encompass Michigan, Impart Alliance. Our recommendation for next year is a $4 per hour wage increase rather than the $1.50 per hour. We think unless we get to a starting wage rate of $18 or $19 per hour, we're really not going to be able to recruit. Both families and providers will be unable to recruit new direct care workers. Perhaps they can keep the turnover at a somewhat manageable level, but we need to be able to recruit new workers. And then also in terms of dollars, and I realize this is not an appropriations hearing, but just to emphasize what we're talking about in terms of cost, our best estimate to do a $4 per hour wage increase for both behavioral health and long-term care is about $215 million in GF dollars. So that's our emphasis on wage issues. Again, we fully support the training initiatives. We have included in the packet a proposal that MALA is presenting to the legislature on training for the direct or immediate supervisors of the direct care workers, because it's equally critical that we have a strong network of immediate supervisors to maintain workforce stability. This proposal would be an online learning management system, 20 courses, approximately 40 hours of training with other educational tools in addition to the actual online visual videos, and it would be voluntary. It would be at no cost to the participants in the training. We estimate a pool of potentially 40,000 supervisors, current supervisors, and future supervisors would be able to take advantage of the training. It's all part of professionalizing the workforce, creating a career pathway for direct care workers and supervisory staff. And we've also included in the packet our proposed boilerplate language for next year on the supervisory training. So I think to really bring it to life, it's funding, it's training, credentialing, competencies, statewide awareness campaign, and there are some other more specific initiatives which could be helpful, one of which would be revisiting criminal history requirements. We fully support the FBI check requirement for licensed residential settings, and we need suitable and capable direct care workers. But there may be an ability to create a rehabilitation review process and some flexibility that would make it easier to recruit new staff. So that we're immersed in the issues. We appreciate the opportunity to testify the work of this committee and the legislature, and we are available at any time to provide additional information.
Thank you, Mr. Stein. Colleagues, anyone have any questions for Mr. Stein right now? Thank you. I know we had one more presenter, but thankfully she is on the committee. And so we can have her talk another time to us, which is great. And so with that, we don't have any absent members. Everyone have a nice legislative break. And we'll, in a couple of weeks, I will see you all, and we'll get back to this important work. The committee's adjourned. Thanks, everybody.